failure to thrive. Uh, so over to Dr. Priyanka.
Priyanka, please share the.
Is it visible now?
Yes.
Yes, yes.
So I'm presenting the case of 11-month-old female baby, date of birth 28th of August 2023, hailing from Kasargod. Informant is both father and mother, and both are partially reliable. Both are partially reliable because mother is having a seizure disorder, psychiatric illness from 13 years of age, and she is on medication, but she's not complained on medication. And the father is not there with the child the whole day. That is why the history is partially reliable. Presenting complaints: 11-month-old female baby presented with history of poor weight gain and development delay on irregular follow-up, presented with complaints of rhinitis, cough, fever for 3 days. History of presenting illness: the history started with rhinitis in 3 days. Initially, it was watery type of discharge. Then it became mucopurulent type, causing nasal block, and it was associated with noisy breathing. And history of cough since 3 days. It was insidious in onset, non-paroxysmal type, wet type of cough, which was present throughout the day, associated with noisy breathing. There is no history of post-acid vomiting, bluish discoloration of the body, breathing difficulty, or increased efforts in the breathing. And history of fever since 3 days. It was insidious in onset, high-grade fever, which was continuous type of fever with no diurnal variation. It was relieved with taking paracetamol. There was history of poor activity noticed by the mother during the high-grade fever spikes. In between the fever spikes, child was active, and the fever was not associated with any rash. There is no history of feeding difficulty. There is no history of sucrose cycle. There is no history of any URI contact. No history of any skin infections, loose stools or vomiting. No history of seizures. No history of any poor activity or lethargy.
Priyanka, previous slide. What are the importance of all these things in a child presenting with the respiratory infections?
In the history of feeding difficulty, because I just want to know whether this infection is, whether in complicated infection like pneumonia, which is causing any feeding difficulty. And also this is a child with history of poor weight gain. So to look for any danger signs, I've asked history of feeding difficulty. History of sucrose cycle, because there's a history of poor weight gain. So any other causes is there which is causing for this poor weight gain? Along with that, now the child has presented with fever, cough, and breathing infection. Then
also, always in any child less than 5 years in this age group, always ask the IMNCI danger signs. That should be included in every point when you see a child baby.
Then history of URI contact to know whether.
Okay. Can continue.
Since the history started from the history of poor weight gain was present since birth, I would like to start with the antenatal history. Antenatal history is the first child of non-consanguineous marriage. There is no history of any spontaneous miscarriages. Mother's age at conception was 18 years and father's age was 28 years. Mother's weight gain during pregnancy was inadequate, but father doesn't remember how much the weight gain was there, but mother's weight before pregnancy was 36 kg.
Okay. At this, what is the importance of all these things? The mother's weight at the time of pregnancy?
Because we are dealing with a case of a child with poor growth. So we just want to know whether whether the child was getting enough nutrients or something.
Okay. And is there what is the expected weight during a pregnancy for the mother?
Based upon the BMI, if it is less than 18.5 kg, the adequate weight gain should be around 12.5.
Can change the slide.
If the BMI is less than 18.5, the weight gain should be 12.5 to 18 kg. If it is a normal weight, that BMI between 19 to 24.9, the weight gain should be around 11.5 to 16. If it's an overweight, between BMI of 25 to 29.9, it should be 7 to 11.5 kg, and obese woman, it should be 5 to 9 kg.
And that is previously we used to say what's the weight gain for all women, but now it is based on what is the pre-pregnant weight. And just That is the you have to you can see the weight gain is different for in different weight groups. If it is a underweight mother, the only half of that is needed for an obese woman. So that point also is a recent change that you should remember. Okay.
First trimester, the UPT was positive after 2.5 months of amenorrhea. Folic acid supplements were taken after conception, but mother was non-compliant on medication. Mother has history of seizure disorder, psychiatric illness from 13 years of age, but she is not compliant on medication. Hence, she has not taken the medication during the pregnancy. Antenatal scans were done, which was normal. Hyperemesis gravidarum, fever with rash or radiation exposure. Second trimester, quickening was felt at 5th month, taken iron and calcium supplements, but she was non-compliant on that. No history of GDM or hypertension, no history of any decreased fetal movements. There was no regular antenatal follow-up, and the anomaly scan was not done.
That is very important point. That is a must scan for the antenatal period.
In third trimester, mother continued to appreciate the fetal movements. There is no history of GDM or hypertension. The 8-month scanning was done, and it was noted to have the baby was noted to have poor weight gain and fetal growth restrictions. Natal history was a late preterm 36-weeker, 1-day SGA, single female baby. Birth weight was 1.78 kg. Baby cried spontaneously after birth. Was delivered by a preterm vaginal delivery, and child was admitted in NICU. Child was started on direct breastfeeding from day 1. Child had passed meconium and urine within 24 hours of life. In view of this low birth weight, child was admitted, and on neonatal day 2 developed NNHB, and they had a incompatibility setting, OA incompatibility setting. And baby was given phototherapy for 3 days and discharged on neonatal day 7. NBS was done. It was said to be normal. At the time of discharge, baby was active, feeding well at breast, and discharge weight is not known. After discharge, child was given direct breastfeeds. Breast milk was adequate according to the mother. Let down reflex was present. Baby was fed on one breast for 10 minutes. Mother used to switch
one
the
comment. It will be better to avoid abbreviations like NBS and NHB and all. All may not be familiar with, may not be using this everywhere. Okay.
newborn screening was done. It was normal. After discharge, child was given direct breastfeed. Breast milk was adequate according to mother. Let down reflex was present. Baby was fed on one breast for 10 minutes. Mother used to switch breast before completely emptying from one breast. And child was irritable and crying after each feeds. Sleeps for 1.5 hours. No proper night feeds were given and passed urine 5 to 6 times a day and stools around 3 to 4 episodes per day.
What is the importance of these things?
Because the mother was breeding only for 10 minutes and she was not completely emptying one breast before the other. So the baby would not have received the hind milk, which is like more rich in lipids, which would be requiring for the growth and satiety for the child. The fore milk only will be getting for the child, which will really quenches the thirst for the child. And also, no proper night feeds were given for the child. So there are more chances the child could have gone for hypoglycemia and other events.
Any other importance of night feeds apart from the hypoglycemia and all?
That prolactin.
Yeah, the night feeds will increase the milk production also. That's the prolactin is more produced during night. And you can see the urine frequency is also a little bit less.
It's decreased.
Continue.
Because the proper night feeds were not given by the mother, father started the baby on formula feeds at around 1 month of age on advice from the family members. He used to dilute 1 scoop in 1 glass of boiled water and used to feed half the glass using bottle. Bottle feeds were given at that time. From 1 month of age, baby was on both direct breastfeeding and formula feeds. At 1.5 months of age, child was admitted in Kannur Medical College. Child was taken to hospital in view of respiratory symptoms by the ASHA worker, and child was admitted in pediatric ICU, had low sugars, and child was critically ill, and child was given IV medications and fluids. For 10 days, child was admitted and was discharged. History of this faulty feeding practices and early introduction of this formula feeds at around 1 month of age was properly counseled to the parents, and the improper dilution was also addressed, and they were counseled. Even mother was counseled about the proper breastfeeding practices. The admission weight was 1.8 kg and on the discharge weight was around 2.3 kg.
Any comment on these things?
Here they have started on an early formula feeding because the night feeds were not ensured. And also they have started on bottle feeding. So that would have led to the nipple confusion in this child.
And also, but when they intervene, this within 10 days, child had an adequate weight gain. That means child may not be having any other causes for the poor weight gain. If the child is having any systemic causes and organic problems, child may not have gained this weight in this period. So probably child may not be having other issues apart from the IUG or low birth weight. Continue.
This is the weight for age plotting for the child. Initial birth weight was around 1.7. The admission weight was 1.8, and after 10 days of hospitalization, the weight improved after proper advice on breastfeeding techniques. Following discharge, mother was not feeding the child properly, not letting other family members to take care of the child. At around 2 months of age, child had attained social smile. At 3 months, the child was brought to IMCH casualty by a child welfare officer after the father launched a complaint citing neglect of the child by the mother and improper feeding. Child was evaluated. Detailed evaluation was done to rule out other causes for failure to thrive. Counseling for parents were given, started on supplements, formula feeds, catch-up immunization was also done. The child was discharged after 10 days of hospital stay. The admission weight was 2.4 kg and the discharge weight was 2.8 kg. Child was handed over to the Child Welfare Committee. Proper follow-up and weight gain monitoring from nearby health center was advised. Child Welfare Committee had handed over the child to the mother on the same day after mother had made an issue. Under father's written assurance, baby was handed over to the mother. No proper follow-up was done or no catch-up immunization taken after that.
Here also what you can see, the child always post-admission child is gaining adequate weight, and the social issues are causing most the problems here. Continue.
Following discharge, child was on direct breastfeeds and formula feeds. Child attained mother regard at around 4 months of age. At around 5 months, they started on complementary feeding with ragi. The ragi they used to prepare with 2 tablespoons of ragi. They used to mix in water with sugar. 1 teaspoon of sugar was added, and they used to feed daily once a time. Then head control was not attained, and cooing was present at around 5 months of age. Child was now being fed with ragi once a day, breastfeeding 3 to 4 times a day, along with formula feed of 30 ml 4 to 6 times a day.
Pediatric case presentation and you and pediatric case presentation and case presentation.
At 6 months, child had no neck control, not reaching out for objects. At 10 months, child came for follow-up in IMCH and noted to have poor weight gain and a developmental delay. Weight was only 4.4 kg. Counseling was given by the dietitian and advised admission and measles vaccination, but they were not willing and went DAMA. Now came with the above-mentioned complaints. There is no history of tightness of limbs or difficulty in changing the diapers while changing the diapers. No history of any loss of attained milestones.
Is there any comments from the so far history? We are coming to the dietetic history in detail. So Priyanka, you can continue that history.
Immunization history. Birth dose of vaccine was taken. Catch-up immunization was given at 3rd month. No further vaccines taken. No AFI reported BCG scar is present. Developmental history, gross motor, neck control was attained around 10 months, rollover around 11 months. Doesn't sit with support. Developmental age is 5 months and developmental quotient is 45%. Fine motor, bidextrous reach at around 8 months. Unidextrous approach around 11 months. Currently, there is no transfer of objects. Developmental age is 6 months. Developmental quotient is 54%. Then social milestone. Social smile was attained at 2 months of age. Mother regarded 6 months. Stranger anxiety at 8 months. Now, currently, the child doesn't say tata bye-bye. Developmental age is 6 months and developmental quotient is 54%. Language milestones. Alert to sound at around 2 months. Who's make sound around 5 months. Laughs loud at 7 months. Monosyllables by 10 months. Now, currently, the child doesn't say bisyllables. Developmental age is 6 months and developmental quotient is 54%. Impression is there's a global developmental delay.
What about vision, hearing, and all?
Vision and hearing is normal. Slide is
Slide move ചെയ്യുന്നില്ല.
moving along. Vision and hearing is normal. And impression is global developmental delay.
Is anything is more affected? In all fields?
Motor, gross motor is most common, like mostly affected, but other milestones are also affected. Next, diet history.
Priyanka, there's a problem in this case of assuming a global developmental delay. This is a very, very complicated social issue is involved. Unlike another situation, analyzing the developmental milestones and branding it as a global delay, you may go wrong.
Yes.
Because definitely we can understand the reason for the the growth parameters slow in. Definitely the child mother with psychiatric problem may not be feeding. Lot of reasons obviously are there. In that context, we expect this thing. And that is well demonstrated 1 week of feeding. It is simply, as Dr. Sindhu rightly pointed out, very unlikely that there is another coexisting problem like renal or cardiac or whatever. It is definitely due to nutritional. About the other social language delay, what you need to tell a little more in this case is, what is the support from the family? The mother, the social, the stimulation, everything definitely will be lacking or a perverted style of behavior from the mother will be there. So, if there is a very good support from the other members, this is the case where we need the apart from the father, mother, other family members details and the support is very important. Because in this case, the language and social part delay may be a bit contributed by the stimulation. Father is not there and the mother is abnormal. Intellectual problem, psychiatric problem. How can a normal development in the social and language happen without the stimulus? So, rather than before you brand it as a global delay, you need to be cautious. It can be only the growth failure part with the gross motor, which is understandable. Only thing is the fine motor part. Fine motor and motor are together. Okay. So you should be conscious about the social language part and branding it as a global, because very important that you are commenting about the ultimate potential of the baby. Okay. Okay, we'll go ahead.
Diet history. Child was not properly breastfed. Exclusive breastfeeding was done for only 1 month. From 1 month of age, child was on board breastfeeding and formula feeds. Initially, formula feeds were given at improper dilution. After admission at 1.5 months, proper dilution of the formula feed was advised, and secondarily, night feeds were ensured. Complementary feeding was started at the beginning of the 5th month. Initially, it was started with ragi. Currently, child is on formula feeds along with breastfeeding, and bottle feeding is also being practiced. Diet history. Currently, the calories, there is observed calories around 550. The required expected is 1110. This is for calories observed in addition to the breastfeeding, and there is a deficit of 550 kilocalories. Proteins of observed is 12.1 and an extra of 1.6 gram. The diet history, what is lacking is there is lacking of intake of fruits, vegetables. There are mother is not giving any vegetables, and she's only feeding with cow's milk and ragi. Even the complementary feed, she's only giving once a time. No feeding with amrutam powder or any other formula complementary feeds. She's not giving.
Priyanka, actually, when child is on complementary feeding, how will you calculate? How will you determine what is the calorie to be taken? What's the IYCF recommendation? How much the child should get?
IYCF, according to this 11-month-old child, should get 300 kilocalories apart from the breast milk. But in this case, the mother was not properly feeding the child. So we can't take the IYCF cutoff. That's why we have taken ICMR guidelines for calculating the calories.
And whether the mother is getting, you can say there is a, even though you say the protein is high, apart from the milk, there is no proper protein source also.
I know.
They are not taking any pulses or any non-veg food items included. And what are the other issues? What is the consistency of the feeds they are giving? Have you asked whether it is very loose or?
It's very loose because they are feeding the child through the bottle feed. So it's
the complementary feeds also through bottle feeds.
Through bottle feeds they are giving.
That also to be highlighted. So what are the issues you identified in here and all? This is the main, because now we have the social issues and the nutritional are the main points for this child solve the problem. So you want to specify what are the problems in the feeding you identified.
One is the mother is like feeding the child with a bottle feeding, which is like we have advised her, but not she's not following. And the other one is they are advised to give vegetables and other fruits to include in that, but she has not included that thing. Even we have advised to give her daily egg also, not being given. Then even the formula feeds, we have asked her to increase the quantity of the formula feeds, but she's like giving only 30 ml every, that too only 4 times a day. And also even ragi also we have advised her, the preparation techniques also we have advised her, but
so in the complementary feeding, usually we will take a detailed history of breastfeeding, but many points in the complementary feeding are usually missed. So I think all of you can refer this IYCF guidelines and the indicators. Next slide. You can see these indicators that will that points you have to concentrate when taking the complementary feeding history. This is the revised one in 2021. So next slide. There are some specific indicators for this complementary feeding, that is whether they are taking the solid feeds, whether there is a diversity is there, whether there is a minimum meal frequency, whether are they feeding on bottle, all these things are included, whether there is a sweet beverage consumption is there, whether minimum vegetable consumption, all the points should be included while you are taking a complementary feeding history. Next slide. This is the one thing in the complementary this is the complementary feeding history. The minimum dietary diversity should be maintained during the period. That usually we start with the ragi or rice the kayapodi, and usually continue it till at least 1 year. But 2 months period itself, you need to introduce the variety of food items. Each child should consume 5 different groups in every day, including the breast milk. So in the daily intake, there should be 5 different categories. You can see here only 2 or 3 categories are included in child's diet, and make sure that it is included in every child, and that should be included in complementary feeding history. Next. And this table is also very important in IYCF. That is, what is the extra calorie needed and what is the texture of the feeds you should give. Now child is 9 to 11. It's almost 1 year old child. Child should be taking small this family, this at least this finger foods mash a little bit, but what do you call that? Should have lumpy foods to be introduced for this child. Still, child is feeding on liquid diet. It should be developmentally appropriate, but they have to train it. If child is having a mild development delay, we have to consider it, but you can gradually introduce this critical time period itself. Next slide. Okay. That is some, when you have complementary feeding histories, I think most neglected part in our teaching and all, we have to give more importance because all the nutritional deficiencies starts only during this period. In our area, breastfeeding is going on relatively better, but complementary feeding is, we need to give more attention during this period.
Priyanka, one point, in this case, definitely many points are needed in the complement, rightly pointed by Sindhu. 1 or 2 points in your calculation, 550 calories are there. But you look at the milk, the 50 ml milk is the morning, another 50 ml milk, and there is a 30 ml into 4. Total 220 ml of the diet is constituted by the milk. Okay. And in that situation, always ask and verify how was the milk was constituted. Is it right or diluted? And you need to double check it by asking how many packets of the milk powder they are buying. That is to be, otherwise. It may be diluted. Second thing is, you're depending on others. Mother's milk also will be inadequate. So allotting and thinking that much of energy from the milk again will be very likely to be wrong. Always ask about how many a packet of milk powder they are buying. That is very important. Okay. So nutrition history was inadequate in this case. So important in this case. Okay. കുറേം കൂടി കാര്യങ്ങൾ അതിൻ്റെ അകത്ത് വരേണ്ടതുണ്ട് സിന്ധു പറഞ്ഞ പോലെ. Okay.
Family history. This mother, the mother's father died at a very young age. At around the mother's age was around 3 months of age, and mother remarried at around 13 years of when this mother had 13 years of age. From that time only, the mother was having psychiatric. The mother used to get abused from the family members, and also from the father. And after marriage, the mother and the husband is living separately. They are separated from the mother.
Can you make me host so that I can mute those who are remaining unmuted, so that you can continue that. Please make me host.
ഒരു വയസ്സിലൊന്നും അങ്ങനെയൊന്നും പിള്ളേർ ചെയ്യുന്നല്ല.
Okay. Just now,
Okay, you can continue, Priyanka.
So the history was like the mother and the father, after they got married, they are separated from the family and they are living at different places. So their proper antenatal follow-up was not there because they were staying at different places, and the father was economically, like socially, they were insecure, so they didn't have much facilities to even the mother's weight gain. When I asked about the history about the nutrition for the mother during the pregnancy, they were like history like father was not able to afford the food most of the time, and so they used to stay in distant relatives of the father's house. And even after delivery, for taking care of the child, only the father and mother was there. No support from the maternal grandmother was there. And they also received during this after pregnancy, after delivery, also the mother received abuse from her mother and her father also, stepfather. Socioeconomic history. Mother is educated up to 10th standard. She's a homemaker. Father studied up to 12th standard. He's a manual laborer. They live in a rented house, 3-membered with 2 rooms. For past 3 months, the father is unemployed because he had fracture to his left arm. So there is no income for the families for the past 3 months. They are not having any insurance, and according to modified Kupuswamy scale, they belong to lower group.
Priyanka, what is the social support from this Anganwadi and all the other support system for them?
Because they are usually migrating, like staying at different places. During the antenatal period, and also during the delivery, like first 3 months, they had received care from the ASHA workers. Regular visits were there by the ASHA workers. But after that, following discharge and all, there was no proper visits because they were staying at different places.
Okay, whether they were referred by the child care protection group, and whether there was any further follow-up through them.
No, there was no further follow-up through them. No further follow-up through them, or through the ASHA workers, there was no follow-up.
Whether they are having a mother-child protection card with them?
No, they are not having.
They were advised immunization from this their PHC or any other area. It was advised apart from the medical colleges.
No, because they were not going to any of these centers, like primary health centers, or no visits were done by them because they were like shuttling between many places.
So from the history, what is can summarize and
11-month-old, late preterm, small for gestational age child, partially immunized with mainly a gross motor developmental delay, and the other milestone delay may be due to psychosocial issue with multiple hospitalization in the past, with history of poor social support, social and family issues, presented with history of poor weight gain and diet deficient in calories and good quality proteins, with cough, rhinitis, and fever for 3 days.
probably what you think this child is having a history-wise diagnosis?
Mainly a nutritional cause for the poor weight gain, and also psychosocial issues which has led to this poor weight gain.
And probably a pneumonia, complicating by an infection.
A little bit more of a maternal problem is needed. So what you said from 13-year onwards, the mother is having seizure and psychiatric problems. Okay. To what extent is this problem? You said they are not taking the drug. Is he still having seizures? During the pregnancy, was there any seizures? What is psychological status? All these things are important because in planning the further about the baby, most important is the maternal, physical, mental, attitude, everything is so important. So her fitness, that is one side. The second thing is, we are having a doubt about the development delay also. So in that situation also, whether there is an underlying problem heritable from the mother. So two ways, the maternal disease details are needed. Okay. What do you think? She has studied up to 10th standard and all. So about her intelligence situations, about emotional situations, attitude for the baby, is physically even now what is it? All those things are important here. Okay. Go ahead.
Coming to examination. General physical examination. Child is irritable but consolable by the mother and is during interacting
Means there is a bonding with the child and mother still there. If the
vitals, pulse rate is 134 per minute, regular in rate, rhythm, good volume, normal in character, no radial or radiofemoral delay, all pulses felt. Respiratory rate is 62 cycles per minute. Workout breathing, there is increased subcostal retraction. Temperature was 99 degree Fahrenheit, is measured in the right axilla. SpO2 was 94% and BP was 9460 measured in the right upper limb. Pallor, there is moderate pallor, no icterus, cyanosis, clubbing, lymphadenopathy or edema. Head to foot examination.
Priyanka, go to the previous slide. So you examine the patient during a acute illness. Okay. And the pulse rate seems to be 134. Okay. So the other signs also are there, tachypnea, other things also. Is the patient in the ICU now or recovered back and
It's child is recovered back and child is in the wards.
in that situation, you need to tell the latest pulse rate. Okay. Because when you're present is saying pulse rate is 134 for an 11-month-old baby. Okay. That is 34 is not acceptable. So this is at the time of that respiratory problem, distress and all. That's acceptable. Okay. But once the stabilize and then transfer to the pneumonia part is better and you are having the other problems. At that time, repeated, the vital signs will not be like this. Okay. Otherwise, you need to explain. Okay. But that's why. If still the patient is a pulse rate is 134, what does it mean? What do you need to exclude? There is another reason for that. Maybe there's a cardiac problem, patient contribute. So that is important.
there's anemia is also there, sir. Moderate anemia is there. That may be contributing.
Anemia per se may not be able to explain this tachycardia. Okay.
And I must mention also about the skull. There is no caput quadratum. There is no costochondral bleeding. Wrist widening, of course, I cannot make out very well from this picture. So because, micronutrient deficiency signs you must try to mention when you are talking about this. Because very important, rapid growth, head size, and then usually it will be there. And here the chest seems to be normal. There is no this thing, yeah.
Okay.
Sorry for my interruption.
Sir, it is welcome always.
Now the saturation. Okay. It is above 94 now, saturation?
Above 94, sir.
Okay, go ahead.
Head to foot examination. Head size, shape normal. AF is open with 3 into 3 centimeter. Face, no dysmorphism. Hair is lusterless, black in color. Eyes, pallor is present, no icterus, no cirrhosis, no signs of vitamin A deficiency. Ears normal, nose normal. Oral cavity is moist, tongue is moist. Dentition, there is no tooth has erupted. No gum bleeds, no ulcers, no oral thrush. Neck, normal. Chest, normal. Axilla, there is loose skin falls. Trunk, there is in the back, multiple hypopigmented macules are present. Abdomen is distended. Genitalia is female type. Perianal region, there is diaper rash. Gluteal region, there are loose skin folds present. Extremities, there is no edema or clubbing. Fingernails, dirt is present. Skin, hyperpigmented patches are present in the flexor aspect of the right thigh. Spine, normal, no bone tenderness.
You can very well mention there is no vitamin D deficiency features.
Vitamin D deficiency features. Coming to anthropometry.
And there is no dorsal edema also. That maybe you may be trying to, actually, even though there is no pedal edema, in nutrition, you have to look for the dorsal edema. How will you look for dorsal edema?
Have to
Where will you?
dorsal. Dorsal.
How long you need to, but usually we're pitting pedal edema, we look over the medial malleolus. But in nutritional edema, you have to press over the dorsum of the foot for 5 to 10 seconds only. And because this edema appears first over that, unless you press it and look, you will overlook it. I think you must have pressed and looked for it. And the dirt under the nail indicates there is some lack of care, and this diaper area rash and all indicates there is some issues for the caring the child.
Of course, if the child is saying diaper rash or perianal rash with diarrhea, loose portions, you have to think of zinc deficiency also.
Okay, next.
Anthropometry. Weight for age. Weight is observed is 3.6 kg. Z-score, it's coming below -3 standard deviation at -4.7 standard deviation. Impression, severe underweight. Length for age. Length is 61 centimeter. It is less than -3 standard deviation at -4.1 standard deviation. Severe stunting. Head circumference is 38 centimeter. It's less than -3 standard deviation, -5.9 standard deviation, microcephaly. Weight for length, it is less than -3 standard deviation, severe wasting. Mid-upper circumference is 10 centimeter.
So any comment? Severe, you say there is a microcephaly. So any comment? You were telling, this is very important in the point of there is a global development delay.
Yes, ma'am.
We need to complete one more.
Initially, Priyanka was mentioning the head is normal, and then there is a severe microcephaly. So we could have avoided that initial description.
Yeah. Or you can say appears to be small or something like. And you can use you can apply the Dines formula as well, because just whether it is proportionate to the short stature or not. And if you are getting nothing to suggest a CNS involvement, you can just say that you can attribute to that.
Very important in this case. Dines formula is relevant in this case, especially when you are getting multiple parameters, especially the length is significantly affected. Length affected length head overall proportionate
that is why she might have mentioned head appears to be normal. The head appears to be normal for that weight, that length and all. So at that point you can mention.
From the photograph, it looks normal for that this thing.
Yeah.
Yeah.
So you can just mention the comment head size.
I think in the present presentations by PGs, they are not utilizing this Dines formula. In selected case, at least like this, Dines formula need to be mentioned, especially you will make a wrong comment of a microcephaly. It may be the over-exaggerated situation where you are. Okay.
Can I ask one question?
How
much, I'm Parvati, how much, no, the baby was small for date, no? So shouldn't you give
preterm
allowance for that also? Preterm, small for date.
36 1 month should have given, ma'am. But even if that is taken into also consideration, this height and weight is coming below the -3 standard.
Length, 11 months. Length.
And also usually we don't give much allowance for the IUGR, but now they says that you will don't try to overfeed them. You just be maintain in between above third centile, you try to maintain, but don't aim at 50th centile. It's a but
Actually,
for
you
this
have to watch the weight chart and then
you have weight chart. Can you show the weight chart once again? You can see actually the
yes.
flow should be more. In the dipping should not be there. It should be a curve like that. Even if it's a very
Here there is
even a
definite. Here there is definite.
definite fall and down sloping of the curve is there.
And you should not cross the lines also, because then you have low birth weight children being fed you have early onset of diabetes and adult onset diseases in an intrauterine retarded child.
Sindhu, some points about this low birth weight. Which chart you should be using in a low birth weight follow-up case? The same this chart you will do.
So low birth weight we are using same chart.
Which chart?
But in the preterm they are using up to that age. These charts are using.
Pendant chart.
Pendant charts and the inter.
There are two types of IUGR situation. It's a proportional, symmetrical and asymmetrical. In a asymmetrical situation, last trimester, some muscle insufficiency and all, you'll get a catch-up weight growth. So catch-up weight growth, there can be a crossing of the centiles crossing it. So that situation should be considered ഒരു ബാക്കർ ഹൈപ്പോത്തസിസ് എന്നെല്ലാം പറഞ്ഞിട്ട് അങ്ങനെ ഭയപ്പെടേണ്ട ആവശ്യം അവിടെ ഇല്ലല്ലോ.
There also now I think there is a concept that should not be cross very fast. You maintain between the 10th centile and at least 25th centile range may be more appropriate.
Okay, അപ്പോൾ അതൊരു പോയിന്റ് ആണ് because
but child is on breastfeeds alone and catching up anything, that is okay.
അതെ, അപ്പോൾ breastfeed alone ആണെങ്കിൽ the catch-up growth overshoot also is
acceptable.
Don't try to feed and make very fast.
Overshoot.
Overshoot. That's acceptable alla. Right. Okay. Continue.
Under systemic examination, respiratory system inspection, trachea and spine appears to be in center, apex beat not visualized, all areas move equally with respiration and no dilated veins or scars. In palpation, trachea and spine appears in center, apex beat at fourth intercostal space at mid-clavicular line, normal in character, all areas move equally with respiration. Percussion, resonant note heard bilaterally equal. Auscultation, normal vesicular breath sounds are heard bilaterally equal in all lung fields, with bilateral fine inspiratory crepitations heard all over all areas. Per abdomen examination, inspection, abdomen appears distended, umbilicus in center, all areas move equally with respiration. Palpation, liver is palpable 2 cm below the right costal margin, soft in consistency, round borders, liver span is around 6 cm. Slightly high for this age group. Spleen not palpable. Percussion, tympanic note heard, no free fluid in the abdomen. Auscultation, bowel sounds are heard. CVS examination, S1, S2 heard, no murmur. CNH examination, power of more than 3/5 in all 4 limbs. Tonus reduced. Reflexes are normal. Bilateral plantar extensor.
So you told the abdomen is distended. What's the reason? What may be the reason for that distension?
Because of the SAM message, the chest and like every chest and all is very protruded belly because of that.
You can have protruded belly. What may be the contributing factors? There can be some hypotonia already is told, and there can be associated vitamin D deficiency. That may be well evident, clinical evident when the child starts growing. And there can be hypokalemia that is usually associated with the malnutrition.
In this case, in the general examination, always more important points, all the micronutrients. Forgot to mention about the vitamin A part.
Sir, vitamin A paranju. Sir, they have mentioned all the, there was no features of vitamin
The
A.
anterior fontanelle you mentioned, okay.
Yeah.
Sir, in that context, all the other evidences of the other vitamins, especially vitamin D, because you don't expect the vitamin D florid situation now. On recovery only it will be occurring. But maybe all the other things are important, and especially micronutrient and electrolytes, all deficiency factors can be there. So general tone is so important, especially when abdominal distension cannot be explained otherwise. So you are going to explain two possibilities, hypokalemia or vitamin D with a visceroptosis. So that is important. But in this case, liver palpability only 2 centimeter. So visceroptosis less likely. Here in the CNS examination, you said that tone is reduced, power is 3 out of 5. Okay. So in the general examination, it was not looking like a floppiness on
The child is cross-legging and then flexing and everything. Yeah.
Putting the legs in his mouth.
Yeah.
Maybe power you mentioned better as 4. More than 3 it is better for.
That's right. 3.5
is normal. Power is
Whenever
normal.
the power is against this gravity and all the things, some power loss may be there, but it better 4 plus.
4 plus 1. 3 plus 2 or weakness. Okay.
The photo shows as if child is in Buddha posture.
Slightly widened, isn't it?
Sir?
There is widening in that picture you shown. Srinivasan sir also was mentioned. Previous.
This slide.
Yeah. Though the skull is not showing because probably brain is not growing, but you can see that so wrist widening is there.
So bleeding of ribs also.
Something, if you just extend the hand upwards, you can make it more clear.
Possible. Fontanelles are very wide, as you mentioned.
Yeah. At the 9 months, it is 3 into 3 is wide.
Any knuckle pigmentation?
No, sir. No knuckle pigmentation.
What is the importance of that?
Vitamin B12 deficiency.
Okay.
Okay, continue. In between, child is getting nutrition supplements in between. That is why child may not have some of these deficiencies. Okay.
Diagnosis. Pneumonia with complicated SAM. Complicated SAM because the child had pneumonia with a severe acute infection along with SAM. Psychosocial and nutritional issue would be the cause for this severe acute malnutrition. Severe stunting, severe wasting with no edema, microcephaly, anemia, global developmental delay, partially immunized.
The pneumonia, you may say severe pneumonia. Usually we say in a SAM child with pneumonia, we have to consider it as a severe. And you say there was some decreased activity and there are some factors also. Like feeding, there was some difficulty. Now the child might have recovered, but initially child might have a severe. So, sir, any comment on this diagnosis and നമുക്ക് 9 വരെ അല്ലേ സർ സമയമുള്ളത്?
9 stop here.
9.
So
the thing is, the diagnosis complete because what is the reason for all these also should be mentioned in the diagnosis.
That is all the this.
There is severe stunting. So will you attribute it to malnutrition or due to any other reason? Microcephaly, can you attribute to malnutrition or any other reason you will consider?
So what's your comment on how will you
Can I tell one interesting incident if your time permits.
Yes, sir.
Yeah, actually, when I went for a 2-month pediatric undergraduate curriculum to Jabalpur, Dr. Binu Mukherjee, she was associate professor. So she had gone to Tanner, Tanner, no? She underwent this thing, and she mentioned, no, the Barker's hypothesis and this thing, specifically this particular incident. In Britain, no, the Oliver Twist was written by Charles Dickens because so many orphanages were there after the World War, etc. Because so many people have died. So in the rations were given by the government of this thing, British government, and in one particular orphanage, children were not growing, thriving well, though the portions given were the same. In another, the children were growing well. Then they found what they are filtering the distributed food materials, etc. They thought. Then what they did, wonderful this experiment they did. They changed the person, no, the caretaker. One was very strict and stubborn and this thing, without any loving care for these children. In the other one, there was a lady who was caretaker, who was so affectionate and this thing and concerned about the children and this thing, giving so much of love and affection. So they did an experiment. So they shifted this lady to that person, and then they brought the other lady to the place where the growth was not good, and they were suspecting pilferage of materials given. And they found that this thing, the reverse happened. Where that lady went, the growth pattern was subsequently was very bad. Whereas in the other place where she was relocated, the good person who was very affectionate and friendly, there the growth rate improved. That was a great experiment. Okay. So which was done, and then the importance of love and affections in growth is very important. Yeah. Thank
That
you
is
for giving
that
me
is,
this much of time.
Sir, thank you. That is why we are giving importance to responsive feeding, both in breastfeeding and also in
Yeah,
complementary feeding. The
absolutely,
guidelines, they give maximum importance to that point. And also, you can use this as there is a stunting. Always you take the mother's height always. That may be a better thing if you are seeing if they both are with them. And what are some questions are there? Why there's protein intake is high when there is a high calorie deficit. How will you explain that, Priyanka? Dr. Vivek has asked how protein intake is high when there is a high calorie deficit for this child.
But the child is
That
not
usually
good, like high quality protein the child is not getting. Like they are not providing this legumes and all pulses.
And that is one important thing. Our only not at all the quantity, the quality is also very important. Whenever we are taking a dietetic history, this is what we and usually our undergraduate students gets. That is the protein may be high, especially when this is a the protein from a vegetarian source. There should be proper, or you have to take the proper combination. Usually we say we need to combine cereals, pulses, but here they are not at all taking any pulses. So the protein from the cereals may not be utilized. The part may be the milk is they are getting, but may not be adequate. It's not a good quality protein. And also, what are the causes of anemia?
Priyanka, you should have mentioned regarding the quality also when you tell the
I think-
quantity of proteins.
I think
Make
she
it a
had
practice
mentioned
to
something.
make it a practice to tell about the quality also, always in all presentations.
And are we considering any other causes of nutritional anemia? Anemia other than nutritional? Whether child is any supplements, nutrition, iron, folic acid, any supplements the child is getting?
No. Not
No.
on supplements.
I think at this point, there may not be, there isn't enough reason we can consider as a nutritional. Once we correct the things and is not recovering, we may consider. And maternal anti-epileptics, Geeta Madam has asked, but I think the mother was not on any drugs. What are the anti-epileptics safe? Which anti-epileptics are safe during pregnancy? Any comment?
Levetiracetam.
Levetiracetam as
Levetiracetam.
relative considered. But I think the mother was not on any drugs during this time.
Before pregnancy, she was on valproate and levetiracetam.
Mm. Yeah, we should have handled this. But the mother was creating so much problem that the child could not be handed over, and they may not have proper mechanism. They were from Kasaragod. The maternal house is at Kasaragod, paternal house is at Malappuram. So they were in different district. They are traveling the 4th district, admitted in between in Kannur as well. So this child with the global development delay, what are the probable etiology for that?
Global development delay, mainly the gross motor and fine motor part could be due to the nutritional part, and language and the social development, it could be due to the psychosocial factors and the mother's upbringing the child, lack of that emotional bonding for them, not interacting much with the child. So,
and you should consider child abuse as well. The child it is a pure case of neglect as well. So child neglect is considered as a form of child abuse.
Emotional deprivation causes growth hormone changes also. Somatomidins, they have found that endocrinologically also they have this thing.
Which immunization you want to give now on the spot? Admission is a SAM child admitted in hospital. Which is the vaccine you should give?
Measles vaccination.
Yeah, there's a high chance child can get it from the hospital, and if the mortality will be high if this type of child is getting measles. So even at admission, you may give that vaccine.
Whenever you say don't attribute all the thing to mother's problems, it's a collective responsibility. So always you can say about the parents. Even in our mother and child protection card, you can see whenever for developmental stimulation, various pictures are there where they have given equal importance to father and mother.
Actually, sir, here the father is trying to give them out, but he is also very much, because of the financial and the problems, he could not do anything.
This case, in fact, is a very, very, very interesting case which needs a lot of discussion outside a pediatrician's purview. There are few points which comes a little complicated answers for you're branding it as a global development delay. So we are all familiar with the global development discussion, 2 or more modalities are delayed, global development delay. Can you consider like that here? Because there is a problem for the gross motor delay. It is a nutritional only. Okay. Then about the social and language, that again can be due to, again, external factors. I don't say that is not the thing. So all the combination can be due to the social situation only. In that situation, if you are giving a better care, emotional support, good nutrition, everything is 100% recoverable back. So when your branding is a global developmental, that word is having a negative connotation. So whether that is justified here is one major issue. So far we are not familiar with this. The second aspect, the doctor was asking, why not hand over to a third person? There is an ethical issue involved. So it's not such a simple decision to hand over the baby to another person. How can you do that? What we are supposed to do is just like going back to the original situation of a good family support, our previous, not the nuclear family, compound family, where other people are supporting both the mother and the baby together. So both of them should be kept together, and mother is considered as a problem, and that should be supported, baby should be supported. That is the ideal. Not take the baby away and hand over to the other. So it's a major thing. Lot of ethical issues involved. Lot of discussion is there outside our purview. Thank you.
Okay, one thing they have pointed out, you haven't included the development assessment in the examination part. That is very, very important for a PG discussion. Okay, then how will you managing all these things? I think we don't have enough time to discuss the SAM management as mainly the discussion and any points in the clinical discussion part.
Mainly, one is management of this. First is we have to prevent, according to SAM management, prevent hypothermia, like hypoglycemia, and prevent that. So this child at admission didn't have symptoms of hypoglycemia, or the GRPS was normal. Then there was hypothermia was present. So we have advice, even in the ward, the child is having hypothermia because the mother is not cleaning the breast properly. Usually the baby is in full of urine. So we have advised that thing apart from that. Then treatment of dehydration, there was no dehydration at the time. Then
Luckily, this child is not having any edema or dehydration. That is very, very important in the management. If these two are there, it is very difficult to manage a child with this edema or a massive edema or this diarrhea dehydration part.
then treatment of underlying infections, and we have started the child on IV antibiotics, and now now currently the child is better with the respiratory rate has come down, and child is better now.
Okay,
And
are you giving any support to the mother? Whether any psychiatric evaluation was done for the mother?
we have sent a
Anything?
psychiatric evaluation, and they have done a counseling for the mother. And now we are providing, like, for the food security, we have arranged a team where they are providing the food for both the parents and the children, both the child, providing for that.
And you are supplying this all micronutrient as per the SAM management protocol?
Supplying the all micronutrients are being supplied, given to the child. Zinc, multivitamins, magnesium sulfate, folic acid supplementation, vitamin.
Then I will ask one question. What is the vitamin A you give for this child?
This child is less than 1 year, so 1 lakh international units you have to give.
What is the new recommendation of vitamin A supplementation? I think you can go to the next slide. Next slide. These things are we have already mentioned. Actually, I asked her to analyze what are the negative factors. Whatever the mother is having, the father is always trying to help her. Though the other support from the other family members are not there. But you can see the mother marriage is just 18. She is pregnant. And there are so many added problems causing these social issues. You can see a lot of things there. Next slide. So I want to this vitamin D. I think all of you are aware that the WHO has come with this new guidelines for the management of acute malnutrition. That is there are some basic changes that they have removed the acute. It says, you can see it's a management of wasting and nutritional edema. Next slide. So they classify these are 3 groups. Previously, we were concentrating on acute severe malnutrition, but now they're giving more importance to the first 6 months of the management. That is why, because this child was identified at less than 6 months, but there was no proper guidelines for that less than 6-month age group. The child slipped into this severe wasting at this age. So the WHO says we have to address more on this less than 6 months age, that all of you have to go through the guidelines. And the wasting, the moderate wasting, severe wasting, acute, they have removed because the thing may not be an acute onset thing. This child, you can see it's a long term. From this even first month onwards, it is continuing. And sometimes the management is also not an acute process. It is a long term. You have to manage. And the other thing they include either severe forms are severe wasting and nutritional edema are the severe forms. The moderate wasting also they have included in this guideline management. So this new guidelines, everybody can go through it. The Indian guidelines, hope it will come later with this changes. So next. This is the infant less than 6 months. You need to address so many factors that they include if the child's having some birth problems, say IUG or baby, you have to address more. Then you can see non-risk factor for poor growth and development. There comes the maternal problems like maternal psychiatric problems. And if you have a 1-point anthropometry value or sometimes a sequential value. Now we usually say mid-arm circumference valued only from 6 months onwards. The new guideline, it is said that 6 weeks to 6 months, you can take a cutoff of less than 11 centimeters. So this is also included in the new guideline. So it's a very, you can go through these guidelines and find the differences and what are the changes. And the vitamin A deficiency, they definitely says that unless there is an evidence of vitamin A deficiency, don't give mega doses, only give daily supplements of 5,000 units, because this already the liver will be compromised in the malnutrition, so may not be able to handle that much mega dose. If there is a deficiency signs, you can give the mega dose. Continue. So
sir.
I think I want to trust on these points that any child in this age group look for the IMNCI danger signs and any that needs an immediate attention. The SAM also you classified as a complicated SAM if they are having any of these danger signs. Next slide. That is the actually when in OPGAI, when you learn about this malnutrition, I think it is very well covered in OPGAI. So you can see the immediate determinants. This child has almost all. Next slide. That's the child has, when you look low dietary intake, infection is there, the child is a low birth weight, all are contributing. But when you are looking in detail, you can see the underlying determinants like there is a lack of food availability. Even though we have advised them, they may not be able to buy it. They may not be having good health access. Even though we say the ASHA worker, Anganwadi worker should visit all these malnourished child, it is not given and they are not getting the proper care even from the parents as well. So all the underlying determinants are there for this child. And also you can see in the next slide. And the underground you have the poor socioeconomic status, the women basic determinants. These are the cultural problems, all the resource poor, or all the factors are contributing to this child's malnutrition. Okay, next.
WHO.
This thing also one new thing, actually I may not be new, I learned it only during last Nutricon conference, that the WHO has decreased the anemia cutoff value in 2 age group, that is 6 to 23 months and the pregnancy second trimester, it has been decreased by 0.5, that is 6 to 23, it is less than 10.5 they have cut down. What was the hemoglobin of this child?
This child is 7 point.
Anyway, child is having a severe
7.9 severe
anemia. The calcium, all these values are also important. When the phosphorus is very important when you are managing. You should always look for the nutrition recovery syndromes also. So yes. So this Priyanka, you can explain this.
So these are the 10 key interventions which were missed in this case, the IYCF 10 interventions. They have started early breastfeeding started within 1 hour of birth, but the infant was not exclusively breastfed for first 6 months. It was only up till 1 month they have exclusively breastfed. And they have introduced the complementary feeds little early. At 5th month they have started, and age appropriate complementary foods and adequate in terms and quality, it was not there. Quantity also they used to give only once a meal, and still now they are giving only. They have not changed the introduced other complementary foods, only they have continuing with ragi, and they after advice they have started banana, and that too only once a meal they have given. Safe handling of complementary foods and hygienic complementary feeding practices they are not following, because even the bottle feeding what they are doing is they are not properly boiling the bottle feeds. They are just washing it in the normal water. And full immunization and biannual vitamin A supplementation with deworming, it's not done for the child. And frequent, appropriate, and active feeding for children during after illness, including oral rehydration and zinc supplements during diarrhea. This child has not had an episode of diarrhea from the history. Timely and quality therapeutic feeding and care for all children with severe acute malnutrition. This has been like the Asha worker has picked up in the early stage in the at 1.5 months. 3 months, the father has after complaining, 3 months we have addressed that, and now we have advised a 10-month admission, but the bystanders were not willing, and currently now we have addressing it. And education and improved food and nutrient intake for adolescent girl, particularly to prevent anemia, and improved food and nutrient intake for the mother. This was not lacking in this case because the mother was not getting proper nutrition during her antenatal period.
And even now, the mother is not getting the proper feed. So, and also one point, when you are considering the diet of a child, we usually give more importance to the type 1 nutrients, and the type 2 nutrients like this, the zinc, magnesium, potassium, and all are very, very important. That is very important for the growth as well. If you have a deficiency of any of these things, that will manifest as only as a growth failure. There may not be the features of a deficiency of anything specifically. Usually we say stunting as an indicator of zinc deficiency is considered in some points. So that is, you make sure that it is there. And many a time when you are managing a severe acute malnutrition child properly, some of them used to avoid potassium. There's a tendency to avoid potassium, saying that the serum potassium is normal. But that should be there because the total body potassium is usually deficient in these babies. And when when you supplement the magnesium, the sodium potassium pump will start acting, and the more the potassium will go intracellularly with this insulin and all. So there's a high chance child can develop hypokalemia. So never overlook this potassium in management of SAM. So this concept is also very important. This is the investigation of this child, how you can go through you can see the RFT, you can say the low creatinine value may be attributable to this low muscle mass the child is having, that is maybe, but you can see the albumin is relatively stable for this child.
Alkaline phosphatase അത്ര ഉണ്ടായിരുന്നു പ്രിയങ്ക?
നോക്കിയിരുന്നോ? Alkaline phosphatase ചെയ്തിട്ടില്ല.
Calcium, is it ionized calcium?
Ionized
calcium. Ionized. Phosphorus is towards low. So, sir, almost time ആവാറായി. മുഴുവൻ മാനേജ്മെന്റ് സാം പോവാൻ നമുക്ക് പറ്റില്ല. ശ്രീ Geeta madam? Geeta is madam. Any comment?
No, actually, the baby kandale doesn't look ill at all. Probably looks actually well.
Madam, for 1 week management ആയിട്ടുണ്ട്. Whenever we started managing, the child will catch up very fast. That is usually at admission വരുമ്പോഴും.
Because that shows that probably it is only nutritional. But the parents in the head circumference എങ്ങനെയായിരുന്നു? I still feel that Ahmed drug may be having some issue on the baby.
Mother drug എടുത്തില്ല madam ഒന്നും.
Unless she said sodium valproate.
That was much before, madam. Like 13 years start ചെയ്തപ്പോൾ initially valproate levetiracetam ആയിരുന്നു. But during the marriage, after marriage, and conceptional time and antenatal period, she had not taken any medications.
Even doubt whether mother is having real seizures because it started when her father died and some emotional issues and all.
When the mother remarried, the same year the child.
Head circumference ഒക്കെ normal ആണോ? ചിലപ്പോൾ ചില ഫാമിലീസിൽ തല ചെറുതായിരിക്കും, ചിലപ്പോൾ നോർമൽ തന്നെ ആയിരിക്കും.
ഇതൊരു സിമെട്രിക്കൽ IUGR ആയതുകൊണ്ട് കുറച്ചൊരു അവിടെ എഫക്റ്റ് ഉണ്ടായിക്കാണും അല്ലേ ചെറിയ
ഇത്ര വേഗം? Because we have seen a lot of babies of severe, even moderate malnutrition. They all look really like malnutrition. This baby with 1 week ആണെങ്കിൽ പോലും actually it's very
Here, I
early.
think the main problem is one important problem is stunting, which you cannot explain only with malnutrition. So there may be some other reason for stunting. So that is
Yes.
why for the weight for length is may not be that much affected.
Sir,
So
but
that
in the
is why
chart it is very much affected, sir. We couldn't, we thought.
affected.
ആ chart
It
ആ
is
chart ഒന്ന് കാണിക്കോ?
below 3 standard deviation. Okay, but
But all others were -4 and all.
ആ
yes, it is less than 3 standard deviation, but other indicators are more 4.5,
more affected.
5. So stunting is an important problem.
And actually, Srinivasan sir was mentioning the growth hormone has some effect with this psychosocial support may affect with
if
this.
we have the measurements at birth, that will also be very helpful.
We don't have
The length and the head circumference at birth will give a lot of clue regarding the exact cause.
We don't have the measurements at the birth. That is available. No record.
സുഷമ മാഡം എന്തെങ്കിലും
ഇയാളുടെ റിനൽ സൈസും എല്ലാം ഒന്ന് നോക്കിയാൽ നന്നായിരിക്കും. ഈ IUGR ആണെങ്കിൽ അങ്ങനെ അല്ലെ, അൾട്രാസൗണ്ടിലും സം റീനൽ ഇഷ്യൂസ് എന്നൊക്കെ എനിക്ക് തോന്നുന്നു ഒരു അൾട്രാസൗണ്ട് അബ്ഡോമിനൊക്കെ വെറുതെ നോക്കായിരിക്കും റീനൽ സൈസും. Because I feel that this baby is going to do well, like an average thing, if the baby is going to be supported. Doesn't look, I mean, because you are doing a great job. ആരെങ്കിലും ഒന്ന് സപ്പോർട്ട് ചെയ്ത് കൊടുത്താൽ maybe this baby is going to do well. Long-term prognosis.
Any chance of it being a skeletal dysplasia? Significant short stature?
Have you
measured the differential upper segment, lower segment ratio and all?
Check it.
Usually you miss whenever there is standing. That is very, very important, whether it is a proportionate and the mid-pannel height as well, these things to be there.
But short stature cannot be explained just by malnutrition.
Okay.
But definitely this emotional deprivation also will be playing a big role in short stature also.
Geeta Raj madam, this child is managed by your unit.
Yes. Good evening, everybody. This child was, am I audible?
Yes.
Okay, this child was initially admitted in our unit. At that time, I think we had done ultrasound abdomen. We had looked for other causes. We had done an echo. We had done an ultrasound abdomen and all. Now the child is now readmitted for 1 or 2. I think the child has been in the ward for about 2 to 3 days. But the social problems, I don't know how we can solve those social problems. Actually, I don't know. This child was initially admitted and we handed over the child to the child line. I mean, child welfare committee. At that time, like, mother was really getting violent off and on. So the child was brought by the child welfare committee to the hospital, and they were looking after the child every day. One person used to come from there and look after the child. And so we were not actually were scared to hand over the child to the mother. So we handed over the child to the child welfare committee, but the mother gets violent when she doesn't see the child. So they took away the child from there, and they were like they are looking after the child. Actually, father is a very nice person. He's not abandoning them, and he's trying his level best. The mother, I think she doesn't have any seizures actually. That's what I found out, because she told me that she actually one day imitate ചെയ്ത് കാണിച്ചു. ഇങ്ങനെ വരുന്നു, ഇതാണ് എനിക്ക് വരേണ്ട അപസ്മാരം. She told me that. Because like അങ്ങനെ കാണിച്ചാല് she used to get more attention. And she doesn't take any medicines. And psychiatricക്കാര് long ആയിട്ട് depression കുറെ they had done ഇങ്ങനെ analyze ചെയ്തിട്ട് they had given her some medicines, but she doesn't take them. Ipo what we are planning to do is, like, we talk to them for a long time. ആരെങ്കിലും ഉണ്ടോ സഹായിക്കാൻ? അവസാനം ഇപ്പോ they said that she's very friendly with her mother's sister. അമ്മയുടെ അനിയത്തിയായിട്ട് ഭയങ്കര ഫ്രണ്ട്ലി. അവർക്ക് ആൺകുട്ടികൾ മാത്രമേ ഉള്ളൂ. So the father told that, so we have asked that lady to come. We thought we'll talk to her and maybe she will take over this lady and this baby. അങ്ങനെയാണെങ്കിൽ maybe there is a scope for improvement. അത് മാത്രമേ ഉള്ളൂ. Because she will not hand over the child to child welfare committee. She will not adjust with her in-laws. This father's sister is a nice lady. She is willing to look after them. പക്ഷെ ഇവർ adjust ചെയ്യില്ല. And she doesn't adjust with her mother. Mother ഒട്ടും നോക്കില്ല. Her real mother. ശരിക്കുള്ള ഒരു സോഷ്യൽ പ്രോബ്ലം ആണ്.
സ്ക്രീൻ ഷെയറിംഗ് സ്റ്റോപ്പ്.
ഓക്കെ, സോ ഇപ്പത്തെ ഒരു ഇതാണ്. എനിക്ക് ശരിക്കും അഡ്മിറ്റ് ചെയ്യുമ്പോൾ ഭയങ്കര ടെൻഷൻ ആയിരുന്നു. എന്ത് ചെയ്യും, എവിടേക്ക് ഈ കുട്ടീനെ ഡിസ്ചാർജ് ചെയ്യും, എന്ത് ചെയ്യും. ഇപ്പൊ ഡേ ബിഫോർ എസ്റ്റർഡേ ലൈക്ക് ദിസ് ഫാദർ കേം ആൻഡ് ടോൾഡ് മീ ദാറ്റ് ഇങ്ങനെ ഒരു ഇതുണ്ട്, ഡോക്ടർ ഒന്ന് സംസാരിക്കുമോ എന്ന് ചോദിച്ചു. അപ്പൊ ഞാൻ പറഞ്ഞു ഓക്കെ, അവർ വരട്ടെ, വന്നാൽ നമ്മൾ സംസാരിക്കാം. നിങ്ങൾ ജോലി എടുത്തിട്ട് അവർക്ക് എന്താ സഹായം ചെയ്യൂ, അപ്പൊ അവര് നോക്കുമെങ്കിൽ നല്ല കാര്യം. അങ്ങനെയാണ് ഇപ്പോഴത്തെ ഒരു സിറ്റുവേഷൻ നിൽക്കുന്നത്. ആൻഡ് എപ്പോ അഡ്മിറ്റ് ചെയ്ത് നല്ലോണം ഫീഡ് ചെയ്യാൻ തുടങ്ങിയാലും കുട്ടി നന്നായിട്ട് വെയിറ്റ് ഇംപ്രൂവ് ചെയ്യും. സ്കെൽറ്റൽ ഡിസ്പ്ലേസിയ എനിക്കിപ്പോ മുഴുവനും ഓർമ്മയില്ല, പക്ഷെ നമ്മളന്ന് നോക്കിയിട്ടുണ്ടായിരുന്നു മോഹൻദാസ്. ഒരുവിധം സെക്കൻഡറി കോസസ് ഒക്കെ നമ്മൾ കുറെയൊക്കെ അന്നത്തെ അഡ്മിഷന്റെ ടൈമിൽ നോക്കിയിട്ടുണ്ടായിരുന്നു. എനിവേ വിൽ തിങ്ക് ഓഫ് ദി സ്കെൽറ്റൽ ഡിസ്പ്ലേസിയ. ഒന്നുകൂടെ ആ ഒരു പോയിന്റ് ഓഫ് വ്യൂ നമ്മൾ നോക്കാം. എക്കോ കാർഡിയോഗ്രാമും USG അബ്ഡമിനും ഒക്കെ അന്ന് ചെയ്തിട്ട് ഇപ്പൊ അവർക്ക് ഇൻഷുറൻസ് ഇല്ല. സോ ലൈക്ക് മേക്കിംഗ് ദം ഡൂയിങ് ലോട്ട്സ് ഓഫ് ഇൻവെസ്റ്റിഗേഷൻസ് ഓൾസോ ഇസ് നോട്ട് വെരി പ്രാക്ടിക്കൽ. ദാറ്റ് ഇസ് ദ ഇഷ്യൂ. മദർ വളരെ ഷോർട്ടാണ്, അമ്മ ചെറിയ തലയാണ്. എനിക്ക് അന്ന് ഞങ്ങൾ ഹെഡ് സർക്കംഫറൻസ് ഫസ്റ്റ് അഡ്മിഷന്റെ സമയത്ത് നോക്കിയിരുന്നു, എനിക്ക് കൃത്യമായിട്ട് ഓർമ്മയില്ല. അമ്മ ചെറിയ തലയാണ് അമ്മ. അവർ രണ്ടുപേരും വളരെ ഷോർട്ടാണ്. കണ്ടാലൊരു അണ്ടർ വെയിറ്റ് ആണ് അമ്മയും അച്ഛനും. രണ്ടുപേരും വെയിറ്റ് വളരെ കുറവ്. അമ്മ എനിക്ക് തോന്നുന്നു ഫസ്റ്റ് അഡ്മിഷൻ ടൈമിൽ അമ്മയുടെ വെയിറ്റ് 40 അത്രേ ഉണ്ടായിരുന്നുള്ളൂ. ഇപ്പൊ ഞങ്ങൾ നോക്കിയില്ല. നൗ ഷി ഹസ് ബീൻ ഹിയർ ഓൺലി ഫോർ 2 or 3 days. ഇന്നിപ്പോ രാവിലെ വയലന്റ് ആയിരുന്നു. അമ്മ കുട്ടിയുടെ അടുത്തില്ല, അച്ഛനാണ് കുട്ടിയുടെ അടുത്തുള്ളത്. ശരിക്കുള്ള സോഷ്യൽ പ്രോബ്ലം ആണ്. ഐ ഡോണ്ട് നോ ആക്ച്വലി ഹൗ ടു ടാക്കിൾ ദ ഇഷ്യൂ. ഇഫ് എനിബഡി ക്യാൻ ഹെൽപ്പ്. കുട്ടി അമ്മയും കൂടെ അവിടെയും പോയില്ല. ഷീ വിൽ നോട്ട് അഡ്ജസ്റ്റ് വിത്ത് ദ ചൈൽഡ്. ഞങ്ങൾ പറഞ്ഞു കുട്ടി അവിടെ പോകാൻ അവര് അതെ, പക്ഷെ ഷീ ഈസ് നോട്ട് വില്ലിങ്. ഷീ വിൽ നോട്ട് അഡ്ജസ്റ്റ്. അങ്ങനെ എല്ലാവരുമായിട്ടും അവർ അഡ്ജസ്റ്റ് ചെയ്യില്ല. അത്രയും അബ്യൂസ്ഡ് ആണ് തോന്നുന്നു ആ ചെറുപ്പത്തിൽ. ആൻഡ് ദിസ് ഈസ് എ ലവ് മാരേജ് ആക്ച്വലി. ഇവര് ഇഷ്ടപ്പെട്ട് കല്യാണം കഴിച്ചത്. ശരിക്കും അയാളെ എനിക്ക് ഐ റെസ്പെക്ട് ഹിം എ ലോട്ട് ബിക്കോസ് ഹി ഈസ് നോട്ട് അബാൻഡനിങ് ദം. അയാള് കൂടെ തന്നെയാണ് ആ സ്ത്രീയുടെയും ആ ലേഡിയുടെയും കുട്ടിയുടെയും കൂടെ. ആൻഡ് ഹിസ് ഫാമിലി ഈസ് നോട്ട് ഫോർ ദ മാരേജ്. ഹിസ് ഫാമിലി ആക്ച്വലി നല്ലൊരു ഫാമിലിയാണ്. അവരെല്ലാവരും വെൽ ടു ഡു ആൾക്കാരാണ്. പക്ഷെ ഈ കുട്ടി അവിടെ അഡ്ജസ്റ്റ് ചെയ്യും. സോ മെനി ഇഷ്യൂസ് ആർ ദർ. എനിവേ ഇറ്റ് വാസ് എ നൈസ് പ്രസന്റേഷൻ സിന്ധു. താങ്ക് യു.
താങ്ക് യു. 9 കഴിഞ്ഞു, 9:10 ആയി.
Priyanka has brought out all the important points here. Congratulations, Priyanka.
അതെ, നന്നായി പ്രിപ്പയർ ചെയ്തിരുന്നു പ്രിയങ്ക.
നല്ല ഒരു കേസ് ആയിരുന്നു എല്ലാം കൂടി. സോഷ്യൽ പ്രോബ്ലം യൂഷ്വലി നമ്മളെ ദിസ് സോർട്ട് ഓഫ് ഒരു പ്രോബ്ലം ഉണ്ടാവാറില്ല ഡിസ്കഷന്റെ അകത്ത്. നല്ല ഡിസ്കഷൻ വന്നു. അതുകൊണ്ട്
ഇനി എന്ത് ചെയ്യണമെന്ന് അറിയില്ല സാറേ. ഇങ്ങോട്ട് വിടണം. അഡ്മിറ്റ് ചെയ്യുമ്പോ തന്നെ ടെൻഷനാണ് സത്യം പറഞ്ഞ.
Okay, so I would like to thank you all for being here till this time. Good night. Good night, sir.
Good night.
Good night, all of you.
Good night.
Wonderful. Yeah.